So first of all, my name is Suzanne Lentzsch. I'm the director of the Myeloma Amyloidosis program here at New York. And today I would like to share, I would say, insights into how do we deal with COVID. As you know, we went through, I would say, an enormous wave of COVID infections here in New York. And I think it's important to point out what can we do to manage this crisis, which is still ongoing. And number two, I would like to talk about CRS, cytokine release syndrome, which can occur with CAR T cell therapy, but also with BiTEs and immunotherapy. So let me start. So we know that in multiple myeloma, there's an increased risk of infections. And the question is, why is that? Why have multiple myeloma patients really such a high rate of infections? And here you can see multiple reasons. So first of all, we know that multiple myeloma directly affects your immune system. It inhibits the B cell function. Many of our patients develop low immunoglobulins and have to receive, we call that IVIG, intravenous immunoglobulins. But we also know that the T cells are affected and don't do a good job in multiple myeloma. So the immune system is directly affected by the multiple myeloma. We know with older age and with frailty, your immune system is also more impacted. But at the same time, multiple myeloma therapies itself can cause neutropenia. This is a decrease of the white blood cells that are especially important to fight infections. But when we give treatment for multiple myeloma and you have already pre-damage of organs, for instance, renal insufficiency, we know that those patients also have a higher risk of infections. Unfortunately, all the myeloma treatments have as a part of the treatment regimen dexamethasone. That can cause high blood sugars, and also high blood sugar is impacting the immune system and associated with increased risk. Unfortunately, there's also a gender-associated risk. Patients with female patients have a 20% lower risk to develop severe infections. If you look on the left-hand side of the screen, you can see MGUS and multiple myeloma, the risk for bacterial infections and viral infections. And this is a comparison to the general population. And you can see, interestingly, that even patients with MGUS have a twofold increased risk to get infections, sevenfold increased risk for bacterial infections once you develop multiple myeloma, and a tenfold risk for viral infections. Dr. Hofmeister showed very nicely what you can do to prevent this. And we all have to keep that in mind, that this is really a risk per se in multiple myeloma, but even higher when you get daratumumab or proteasome inhibitors. Most of the infections, you can see that up to 60% are the upper and lower respiratory tract, sinusitis, bronchitis, pneumonia. There was a study in UK in which around 1,000 patients who started treatment for multiple myeloma were randomized to receive either a placebo, that means nothing, or levofloxacin in the first 3 treatment months. And what they showed that was quite interesting is that if you receive levofloxacin in the first 3 months, you have a significantly lower risk to develop infections. We usually don't give our patients levofloxacin because we are concerned of C. diff development, that we really impact the GI tract and cause diarrhea. But I found it was an interesting study, and we should maybe, if we have a high risk, and especially in patients who have a history of severe infections, I think levofloxacin, Levoquin for the first 3 months could be considered. Let's talk about COVID. Unfortunately, this is still ongoing, and we have the vaccine just approved. So I hope the situation will be different in the next 3 months. But what can we do as myeloma community to deal with that, I would say, COVID infection, wave of infection? So let's go back and just to explain a little bit how COVID develops over the course of the disease. So we have 3 stages of COVID. The first stage is an early inflammation. It's where the virus really expands, where patients have a high fever, a dry cough. And if your immune system is active and can do a good job, usually patients get out of that, I would say, initial stage 1 and recover from that. But if your immune system is impaired, or for some reasons we don't know exactly, you go into that pulmonary phase where you develop pneumonia with shortness of breath, where you might need oxygen. We call that the pulmonary phase. And then what happens in stage 3 is a hyperinflammation phase, where you have an uncontrolled inflammation that especially happens in your lungs, where you need ventilation, where you have high inflammatory markers in your blood. And this phase is usually treated with oxygen, ventilation, dexamethasone. Recently, we have the approval of certain antibodies. What are the factors to develop this, I would say, severe case or severe development of COVID? There was a study that was performed in China in which they analyzed patients. What are the patients who have especially, I would say, a bad cause of the disease and a high risk to die? And interestingly, there were two factors. It was older age and lymphocytopenia. And I want to point out that this was a study independent of any underlying cancer. So in the general population, if you have a low number of lymphocytes, those are the white blood cells that, for instance, produce antibodies, but especially fight viral infections. If those numbers were low, the risk for severe infection was much higher. There is, I would say, one study from Spain, which is the best study in terms of giving us what is the risk for multiple myeloma to develop severe COVID symptoms or even die from COVID. So they analyzed 167 multiple myeloma patients from different hospitals in Spain. And what they did is they compared those 167 multiple myeloma patients with 167 randomly selected non-multiple myeloma and non-cancer patients. They made sure that the patients, in order to compare them, matched in terms of age and also the gender, but also of the comorbidities. So what they found was, and you can see the outcome of the patients or the clinical features of the patients who had no cancer and of the multiple myeloma patients. And I want to draw your attention to the ventilation. You can see that patients who did have multiple myeloma had a much higher rate to have a non-invasive ventilation or invasive ventilation. That means an intubation. Non-invasive ventilation, 21% versus 8%. And you can also see that the risk to die or the rate of death was much higher in the patients who had multiple myeloma with 34% versus 23%. So altogether, they concluded that the mortality in multiple myeloma patients, in patients, I have to point out, was 34%. That is pretty high in comparison to 23%. They found some risk factors that especially increased the risk to die from COVID, and it was in males, patients who were older than 65, patients who had active and progressive multiple myeloma at the time of the hospitalization, and with renal disease. So I think that study nicely showed us especially the high risk group among our multiple myeloma patients who might have a high risk to die from COVID. So what can we do and how can we approach changing the initial therapy? I think what is important to point out that multiple myeloma is a disease that needs treatment. I saw many patients during the peak of the pandemic here in New York who did not go to the physician with symptoms and came to the emergency room with hypercalcemia or in paralysis because of a growing multiple myeloma mass in their spine. So I want to point out that multiple myeloma treatment is really important despite COVID. We can individualize a treatment to limit the exposure to potential other COVID patients. So for instance, instead of an IV treatment, we can choose an oral treatment with Revlimid, Ixazomib, and Dex. So this is no IV infusion. We can give lenalidomide maintenance to standard risk patients, and we can add Ixazomib, for instance, in high risk multiple myeloma patients who need maintenance. We can switch bortezomib to weekly instead of bi-weekly. Those are measurements you should discuss with your doctor if you live in a high-risk area of COVID. And I have to say that we adjusted our approach according to the COVID numbers. We had almost no patient visits during the peak of the pandemic here in New York, and we are pretty much back to normality because the numbers are growing up, but they are still an acceptable range. So what are the recommendations for the maintenance therapy? We recommend not to stop maintenance therapy. We know that the relapse is much higher when you do not have maintenance. You can ask your doctor for an extended access to lenalidomide delivery to your house, for instance, for 3 months. Telemedicine visits. I started treatment with patients on RID with telemedicine visits and nurses who draw the blood at home. And I have not seen them for 6 months. So a lot of things are possible with the telemedicine visits. I mentioned already high-risk patients, maintenance, for instance, with RVD or RID, those things are possible. Again, minimizing visits, I mentioned that already, oral regimens, extending the delivery of the drugs. Zomera can be given every 3 months instead of monthly. Again, many tools to diminish the visit numbers. What about transplant? We discussed transplant. I think this is important to really discuss with the doctor. What are the numbers in the local hospital? We stopped transplants during the peak of COVID. This was not due to the fact that we were afraid that patients will get COVID in the hospital, because we have single rooms. We all wear an N95 mask when we go into the rooms. Our transplant floor was COVID-free all the time. We tested all patients who came to the floor for COVID, but it's also a matter of resources. So for instance, if there's no ICU capacity, and God forbid, if you need the ICU, it should be guaranteed that if you get a transplant, that you get a bed in the ICU. So if the ICU is full with COVID patients, that might be the limiting factor. So that's my summary. Keep in mind that multiple myeloma patients have a high COVID-19 mortality. I think we need to protect our multiple myeloma patients. I think, and I'm sure we will discuss that, the vaccine, it's important that also the caregivers for multiple myeloma patients get a vaccine, because those are our most vulnerable patients. You need treatment for multiple myeloma. We cannot afford that patients die or have complications from multiple myeloma because of COVID. Last but not least, wear a mask. That's the best way to protect yourself. So in the second part of my presentation, I would like to talk about CAR T-cell therapy, especially about CRS, and that in patients with multiple myeloma, lymphoma, or patients who have cancer and get CAR T-cells or immune therapy, you might induce a perfect storm. And I try to shed some light in it. What does it mean for our patients? So let me start with a patient. John is 52 years old. He has lymphoma, but you can easily substitute that by multiple myeloma, because the principle of the toxicity in CAR T-cell therapy are the same. So you all know that CAR T-cells are modified T-cells that are given to patients and attack or bind to the myeloma or lymphoma or cancer cells and kill those cells. So, but there are complications with CAR T-cells, and this is a very good example. You can see that our patients received the CAR T-cells on day one, received the CAR T-cells without problems, but 1 day after the CAR T-cell infusion, he started to have high fevers. This is his fever curve. So he was treated initially with Tylenol, and you can see each time he received Tylenol, the fever goes down. But what happened on day 4, so that he developed low oxygen saturation, it dropped below 90, which is usually critical. You should have an oxygen saturation in your blood, 95 and higher. And also his blood pressure was pretty low, with systolic blood pressure below 100. So the patient received tocilizumab, which is an IL-6 inhibitor. I will talk about that, for we call that cytokine release syndrome. And what you can see, and that's very impressive, that his fever went down completely and stayed in a normal range after he received that tocilizumab, which is an IL-6 inhibitor. But something else happened with John. So at day 5, he appeared to be sleepy and he had a tremor. So on day 6, he was not able to name objects and he could not use his smartphone anymore or write. He had a neurological exam that was mainly normal, and also a brain MRI and EEG didn't show any bleeding or seizures or any other abnormality. But the doctor decided to give him dexamethasone, 10 milligrams every 6 hours, for an assumed, we call that ICANN, which is an immune effector cell-associated neurotoxicity. Sounds complicated. In principle means that the CAR T cells not only bind to the myeloma or the tumor cells, it also has an effect on your brain. And after he received dexamethasone, his neurological exam went back. And on the right-hand side, you can see what we're doing. The doctors are not even asking to say name an object. We also ask, write down a sentence. And you can see that on day 0, on the day the patients received the CAR T cells, the handwriting was pretty much okay. You can see how it changed on day 5, and probably on day 6, he wrote something inappropriate, so we had to cross that out. But after he received dexamethasone, his handwriting went pretty much back to normal. Very impressive, and I think very typical for patients who develop ICANS, that immune effector cell-associated neurotoxicity. So, but what are the toxicities of CAR T cell? How do we call that? So first of all, I mentioned already the cytokine release syndrome. It needs careful monitoring, but we can treat this. We have the neurological side effects that can result in change of mental status, confusion, even delirium, inability to speak, but in very bad cases, also edema of the brain and seizures. We also see cytopenias. That means from the chemotherapy and from the CAR T cells, you have prolonged low numbers of your platelets and white blood cells. Other side effects are rare, for instance, that you have low immunoglobulins, infusion reactions directly to the CAR T cells, or tumor lysis syndrome. This occurs rarely in multiple myeloma, usually in lymphoma where you have larger tumor masses, and it's characterized by renal failure. So let's talk a little bit about the cytokine release syndrome. And in general, what is a CRS? It's a condition that results from the release of cytokines from the activated T cells and also from the bystander immune cells. So the whole immune system is activated, and similar when you have a flu or an infection, there's a secretion of cytokines that cause that high fever. The good news is that most of the patients who develop in CRS have also a good response to CAR T cells, and we have a good treatment. We can block IL-6, I mentioned that already, with a monoclonal antibody tocilizumab to really block that CRS. Steroids are used for severe or refractory CRS. The problem is we are afraid that with the steroids, we might block the T cells and also we might block the anti-tumor, anti-myeloma effect. CAR T cells are always in patients in order to really monitor and treat the CRS. So this curve shows you a typical onset and resolution of CRS and neurotoxicity. So CRS, the cytokine release syndrome, usually appears between 1 and 14. It takes in general 2 days before you see the onset of the CAR T cell, of the CRS. And why does it occur? It's usually associated with a T cell expansion. That means you get the CAR T cells and then they proliferate in your body. And during the time of the proliferation, you have those symptoms with fever and also the neurological changes. Here you can see how many symptoms you can have when you have the CRS, the cytokine release syndrome. Very often it's very difficult for the doctor to really separate, is a CRS due to the CAR T cells or is that an infection? But there are typical symptoms: high fever, rigors, but also hypotension and the need for oxygen, hypoxemia. Here is a typical cause of the CRS, and you can see again, this is a day on day 0 when we infuse the CAR T cells. You can see the black curve, how the fever goes up. And then what we also see is in purple that the CRP, C-reactive protein, you might have heard about that, and some of your doctors might check CRP when you have multiple myeloma. You can see the high peak of the CRP, and that's a pretty good marker that we can follow to see what is the cause of the CRS. Again, typical example, when the CRP goes up, you can see that C-reactive protein after 1 day, and associated with the increase of the CRP is also IL-6. So that's also a good marker. And we can remember, we can treat the high IL-6 level with tocilizumab. We know that the severity of the CRS, the cytokine release syndrome, is associated with tumor burden. This is principle, both graphs show the same. Here you can see patients with severe CRS or with no CRS, and it correlates in this case with blasts from leukemia cells. You see that patients with high blasts, you can see more than 50, have severe CRS much higher than patients who have no blasts. So that's why very often we give chemotherapy before we treat patients with CAR T cells in order to reduce the tumor burden. How do we manage the CRS? So we have 4 different grades of CRS, usually grade 1 and grade 2. We observe this. We give patients, if they have low blood pressure, some fluids. We give oxygen if the oxygen drops. But if there's grade 3 and 4 CRS, that means the patient does not really respond to fluid resuscitation. The patient needs medications that increase the blood pressure, or the patient requires more than just few liters of oxygen. Those patients receive tocilizumab. I mentioned that already. This is an antibody that blocks IL-6. The good news is this is an FDA-approved antibodies, and we have quite good experience with this drug as it is used for rheumatoid arthritis and given to those patients in order to block inflammation. Here you can see typical curves, how patients respond to that tocilizumab, to the IL-6 blocker. This is a respiratory rate, heart rate, and on the right-hand side, you see again the C-reactive protein, the CRP, and you see nicely how everything normalizes. The respiratory rate normalizes, the heart rate goes down right away, and also the C-reactive protein normalizes after you block IL-6. I mentioned already that there are other toxicities associated with CAR T cells. Those are, for instance, prolonged cytopenias. We see that patients can have low platelets and low white blood cells up to 3 months after the CAR T cell therapy. We allow usually transfusions and growth factor support like GCSF as patients need this. But let's go back to our patient. So you can see that patient John had really, in the PET-CT, extensive lymphoma. All the yellow masses are lymph nodes that take up high, I would say, concentrations of sugar that is given during the PET-CT, and you can see the activity of the tumor. And you can also see on day 30, almost everything is gone. So the patient has a good remission, probably a complete remission, and had an optimal benefit from the CAR T cell treatment. So at the end, I think it's really important that when you get CAR T cells, you discuss with the doctor, am I strong enough for the CAR T cells? Can I go through the side effects? And what will be my benefit in order really to weigh the risk-benefit ratio? And with this, I would like to end my presentation, and I think we can move on to our discussion.